Hi, everyone. My name is Maly Tiev. I'm a nurse practitioner with NYU Langone Health. Thank you for joining me tonight. Oh, I'm sorry. I can't navigate my slide. Crystal?
Dancing? Yes, I'm here.
I can't scroll through my slides. I don't know why now. Oh, there we go now. Okay, sorry.
Okay. Maly, I'm sorry. Do you mind just starting one more time? We are recording this, and it will be posted on the community network page after.
Okay. I will start over. Hi, everyone. My name is Maly Tiev. I'm a nurse practitioner currently working at NYU Health Langone. I thank you for joining me tonight. Today, I'm going to share insights on non-invasive testing, focusing on real-world application and the management of MASLD and MASH. Use this QR code to record your attendance for this meeting. This program is part of the GAP MASLD MASH Community Network. Scan this QR code to access additional educational content, including Magical MASH disease states, education, and Magical Rezdiffra promotional program. So let's start with a case. Albert is 65 years old, Hispanic male. He has obesity and was referred for elevated liver enzymes. His abdominal ultrasound is remarkable for increased echogenicity consistent with steatosis. He has not drank alcohol since his 20. His medical history includes type 2 diabetes, hypertension, and hyperlipidemia. His lab shows triglyceride of 89, HDL 41, hemoglobin A1C 7.2. His ALT has been elevated in the last 3 years, between 1 to 2 times the upper limit of normal. His evaluation for other causes of chronic liver disease is negative. On physical exam, he has abdominal adiposity, no stigmata of advanced liver disease, and his BMI is 29. So based on these findings in his lab, he has been diagnosed with metabolic dysfunction associated steatotic liver disease, or MASLD. So the next important question to find out is, what is Albert risk for advanced fibrosis? So traditionally, liver biopsy has been the gold standard for the diagnosis of MASH and fibrosis staging. However, because this is an invasive approach, there are several limitations with a liver biopsy. Non-invasive assessment, or NITs, have been widely accepted in clinical practice for the last couple of years, and it has been incorporated in guidelines for the assessment of fibrosis. So today I'm going to go over the common NITs that are currently available for you to order. So NITs are either imaging-based or lab-based. So we will only focus tonight on those NITs that are highlighted in gold. So starting on the top left, this is your imaging biomarkers for fat assessment. You can do this using ultrasound quantitative technique, or MRI study. The CAP score is your FibroScan test, and MRI PDFF is part of your MRI elastography. Down here on the left, this is your imaging biomarkers for liver stiffness. Liver stiffness is a surrogate marker for fibrosis. And so the top 2 exams, shear wave elastography and ARFI, these are your ultrasound technique. VCTE is your FibroScan test, and MRI elastography. So moving to the right top, this is your clinical prediction for fibrosis, where you do online calculation using simple information that you have on the patient. So this is your FIB-4, NAFLD fibrosis score, and APRI. On the bottom here, on the right side, this is your proprietary serum markers for fibrosis. This is a sent out blood sample done by the lab. And so you have PRO-C3, ELF is your enhanced liver fibrosis score, FibroSpec, and Fibrometer. Here in the middle, this is the combined score. So FAST is a combination of FibroScan plus AST. To calculate the score, all you have to do is just download a FibroScan app and you'll be able to calculate from there. MeFib is combination of MRI elastography plus a FIB-4. MAS is a combination of MRI elastography plus AST. To help you calculate the score, you can go to coulditbemash.org. Now, FIB-4 is the first test that is recommended by all society because it is so simple to do. You can get the calculator online. If you use EMR like Allscript or Epic, it can also automatically calculate the score for you. In Epic, all you have to do is type .fib4. In Allscript, there is a calculator section, and you just do the drop down and you'll get the FIB-4 calculator. And all it is you use, it needs age, AST, platelet, and ALT, and you get a score. And so if your score is less than 1.3, this means that the patient has low risk for advanced fibrosis. FIB-4 has a high negative predictive value, meaning that it's a good screening tool to exclude advanced fibrosis in individual with or at risk for MASLD. Now, if your FIB-4 is greater than 2.67, this indicates that this patient is at risk for advanced fibrosis, and therefore you would need additional NITs to assess the patient, or refer to your local GI or hepatology office. So enhanced liver fibrosis, which is the ELF score measurement, this calculates 3 direct markers for fibrosis, and it's a send-out test. You can do this with Quest or LabCorp, and it takes about 2 to 3 weeks to get the results back. The ELF have a good diagnostic accuracy for advanced fibrosis. So with different guidelines, there's different cutoffs. So I usually go with double ASLD. If you have a score less than 7.7, this means that this patient has low risk for advanced fibrosis. But if your score is greater than 9.8, this is your high-risk patient for advanced fibrosis. This ELF is a good test to do if you have no access to the imaging base. Here are all of your non-invasive fibrosis assessment using liver stiffness. So liver stiffness is the ability of an object to resist deformation in response to an applied force. And shear waves travel faster through a stiff liver. So therefore, liver stiffness increases with fibrosis stage. So here are 4 examples of your liver stiffness test. The TE on the top left is that this is your FibroScan test, and you get a report that looks like this. To your top right, this is MRI elastography, and this exam used special padding, and it produced this color elastogram that looks like this. And so red means that there's more stiffness, green is less stiffness. And then on the bottom, these are your 2 ultrasound techniques. So point shear wave elastography and 2D shear wave elastography. So this is how the FibroScan machine looks like. You either have the stand-up one or the portable one. The FibroScan test takes about 5 to 10 minutes to perform, and you get 2 types of readings. You get one score that shows the liver stiffness. This correlates to the extent of fibrosis. The second score is the CAP score, and this correlates to liver steatosis. The nice thing about a FibroScan test is that both biomarkers can be used to assess disease severity in different etiology, including MASH. So I think that it's important for everyone to know how to read a FibroScan test. So what you want to do is you want to look at your report and see if there are 10 valid measurements. So you want to look at your liver stiffness itself and want to determine whether the ranges are consistent or not. What you don't want to see on the report is a liver stiffness, say, one that says 5 kilopascal, another one that says like 10, and another one that says 7, and another reading that shows 12, and another reading that shows 15. These measurements are all over the place, so this indicates that this test is not a good test. Now, you also want to take a look at what was the success rate to obtain the 10 measurements. So if the technician has to do like 12 readings to get 10 measurements, then that's a good indicator that this exam may be good. But if the technician has to do 20 exams to get 10 measurements, this means that the technician kind of struggle a little bit with this exam, and so maybe not a good test. Then the FibroScan test actually measure up to 75 kilopascal for the liver stiffness. So let's just say you have a patient where you don't suspect cirrhosis because based on lab work, the platelet count is 150,000 or greater. On ultrasound, the liver looks normal with a normal spleen size. But when you send this patient for a FibroScan test and you get readings of, say, 50s and 60s and 70s, what you want to question is, are you looking at rib stiffness or liver stiffness? So sometimes what happens is that patients with narrow rib, I see occasionally with Asian female, when we do the FibroScan test, the technician is actually hitting the ribs instead of the liver. Next, you want to look at the IQR and making sure that this is less than 30%. In my clinic, I use 20% as the cutoff. IQR is your quality control metric to tell you the reliability of the liver stiffness test. And so the lower the IQR, this means that the results is consistent across repeated measurement. Next, you want, before I go, I just want to mention with the IQR, if you happen to get an IQR of 0% with the same liver stiffness across 10 reading, that's also not a good test. So even though it's 0, no matter how experienced the technician is, they can't be that good. So something happens with that test, so it's not a good one. Next, you want to look at the imaging quality. You want to see these nice parallel shear wave margin that's shown here on the right side. What you don't want to see are like cone shape or blurry image. Next is the experience of the operator influence the results of the FibroScan test. So to be proficient, the operator needs to do at least 20 to 30 tests to get good readings. Now, there's a couple of limitations with FibroScan that I would like you to be aware of. So patients with ALT or AST greater than 100, or those who have cholestasis, they can have falsely elevated liver stiffness. Patient factors also influence the test results. So patient needs to fast about 3 to 4 hours before the test. And you have to be specific with these patients. You have to tell them nothing by mouth for 4 hours, including drinking water, eating candy, and chewing gum, because sometimes that happens. I usually tell patients no alcohol 2 to 3 days before the test. Those patients who have morbid obesity, BMI greater than 35, what happened is that the distance between their skin to the liver may be a little thick. And so sometimes we have a hard time getting reading. The Excel probe helps in this situation a little bit. Any patients with ascites should not get the FibroScan test because fluid interrupt the ultrasound signaling. And patients with multiple liver masses can have a falsely elevated liver stiffness. This is your MRI elastography on the top right. This technique also uses shear wave technology to produce a multicolor elastogram, which is shown here. And again, red means that there's a lot more stiff area. Green is a little better. Couple things to consider when you're ordering MRI elastography. Patients with a BMI of 45 or higher, they may not fit too well into the machine. Those patients with iron overload or hepatic congestions, they can have a falsely elevated liver stiffness test. Anyone with non-MRI compatible implants cannot get this test. Then patients who are claustrophobic may have a hard time doing this exam because it takes about 15 to 30 minutes to complete. Next, you have insurance issues. So some insurance don't want to pay for MRI elastography because it's expensive. I live in New York, so with our insurance, if you indicate in your NIL that the patient's BMI is greater than 35 and that you feel that FibroScan would not be reliable, sometimes you'll get approval this way. MRI elastography is performed without non-contrast. So if you happen to order MRI elastography with and without contrast, sometimes that will get denied unless you need the contrast to evaluate hepatic lesions. Switching to the non-contrast sometimes get you that approval. So this is a nice table showing the four most commonly ordered NITs. So FIB4, this is the indirect serum fibrosis biomarkers where you calculate using age, AST platelets, and ALT. And if your cutoff is less than 1.3 for your score, this shows that this patient is low risk for advanced fibrosis. If you have a score greater than 2.67, this is your at-risk advanced fibrosis patients. The limitation with FIB4 is that it has a low positive predictive value of about 40%. This means that this is not a good test to rule in advanced fibrosis. This test, because it uses age as part of its calculation, anyone who's older than 65 years old will naturally have a higher FIB4 score. So for those patients who are older than 65, we use a cutoff of 2.0 instead of 1.3. The same goes with those patients who are 35 years old or younger. They will naturally have a lower FIB4. So for these patients, you want to use a different NITs. Now with FIB4, 30% of your patients will fall into what we call the indeterminate risk zone, where their score is between 1.3 to 2.67. So therefore, you need additional tests to determine their risk for advanced fibrosis. The strength of the FIB4 is that it requires minimum data that you normally would have on this patient to calculate, and it has a high negative predictive value, meaning that this is a good screening tool to exclude advanced fibrosis patients. Now, ELF, which is your enhanced liver fibrosis test, this is the sent out blood that can be done with Quest or LabCorp, and it used 3 fibrosis biomarkers to calculate a score. And so if your score is less than 7.7, this is your low risk patients for advanced fibrosis. If your score is greater than 9.3, this is your patients who are at risk for advanced fibrosis. The limitation with this test is, again, it's a sent out test, so therefore cost may be involved. It also have a high negative predictive value. VCTE is your FibroScan test using liver stiffness as your fibrosis biomarker. And so if your score is less than 8 kilopascal, this patient is low risk for advanced fibrosis. Those with greater than 12 kilopascal, this is your at-risk advanced fibrosis. There are a couple of limitations with FibroScan tests. There's multiple confounders that can potentially influence the results, and this test requires experienced operator. The strength of FibroScan is that this can be used point of care exam, and it also have a high negative predictive value. MRI elastography also use liver stiffness as its biomarker, but if you look here, the stiffness range is different from the FibroScan test, so you want to be mindful of that when you're reading your report. So for the MRI elastography, if your score is less than 2.5 kilopascal, this is low-risk patients for advanced fibrosis. If the score is greater than 3.6, this is your at-risk advanced fibrosis. MRI elastography is expensive and not widely available. However, MRI elastography is highly accurate and it has few confounders that will affect your results. So getting back to Albert, he has been diagnosed with MASLD. So the next thing we have to do is determine what is his risk for advanced fibrosis. So he's 65 years old, his ALT is 43, AST is 38, his platelet count is 170,000. And so you calculate his FIB-4 score and it's 2.22. So if you look here on the algorithm on the right-hand side, this is a flow sheet that you can use to, especially if you're in primary care or endocrinologist or obesity specialist, you first want to identify your patient who's at risk for MASH. And so anyone with 2 or more metabolic risk factors, type 2 diabetes, anyone with steatosis on imaging or elevated liver enzymes, you want to assess the alcohol history, do a CBC, get a liver function test, and then calculate their FIB-4. So if the FIB-4 is less than 1.3, then this patient is considered low risk. So the recommendation is to repeat NITs in 2 to 3 years unless clinical circumstances change. If your FIB-4 is greater than 2.67, this is your high-risk patient. So therefore, you want to refer this patient to your local GI or hepatologist office. Now, if your FIB-4 falls between 1.3 to 2.67, this is the indeterminate risk zone. So therefore, the recommendation is to do a FibroScan test next. And if your FibroScan test is less than 8 kilopascal, this is considered low risk. If your FibroScan test is greater than 12 kilopascal, this is your high-risk patient. So you should refer your patient to your local GI or hepatologist office. Now, if your score is between 8 to 12, this is considered medium risk, and it's also recommended that you refer this patient to your local GI or hepatologist office as well. So if we, so Albert fall into that indeterminate risk zone, so therefore he needs a FibroScan test, and his FibroScan test shows 6.7. So if you look here on the chart, it's less than 8 kilopascal, so therefore he is considered low risk, and you can continue to monitor and follow him in your clinic. It is recommended that you counsel Albert on lifestyle modification, treat his metabolic disease, and repeat NITs in 2 to 3 years. And with that, thank you for your attention. I think we have a couple more minutes for Q&A. Are there any questions for me?